Well, I have the pleasure of introducing our next speaker, Dr. Akshay Desai. Akshay is one of our advanced heart disease specialists. He's an associate professor in the Department of Cardiology, or Division of Cardiology, Department of Medicine. And he'll speak on cardiogenic shock and congestive heart failure, and I'm sure he'll touch on malignant arrhythmias as well. Thanks a lot, Akshay.
Thanks so much, Jerry, and it's a pleasure to be here in this critical care section of the course. These are disclosures, none of which are directly relevant. I'm going to start with a question, and then we'll walk into the discussion of cardiogenic shock management. This is a 60-year-old man who presented to the emergency department with 2 hours of crushing substernal chest pain radiating to his left arm with nausea and diaphoresis. On examination, his blood pressure was 82 on 60 with a heart rate of 110 and an oxygen saturation of 95% on 4 liters of nasal oxygen. He was in severe respiratory distress with marked jugular venous distension, bilateral rales, an S3, and cool extremities. His EKG reveals sinus tachycardia and ST elevations anterolaterally with reciprocal ST depressions. He's given medications as listed on the slide and remains hypotensive despite dopamine. Urgent coronary angiography is planned. So the question to you is really which of the following steps is most appropriate as a next step? Would you A, initiate a low dose of beta blocker, B, add a phosphodiesterase inhibitor, C, insert an intra-aortic balloon pump, D, administer thrombolytic therapy, or E, arrange an endomyocardial biopsy? I think we're slowly having some votes accumulate. I'll give it a couple more seconds. Great. Well, I think the vast majority of you here selected a balloon pump, which I think is the correct answer. This is a patient in the throes of an acute myocardial infarction complicated by cardiogenic shock, or at least that's what we would presume. Blood pressure is quite low on initiation, so initiating a vasodilator without hemodynamic data might be challenging. And in this patient who's going to the cath lab, a balloon pump makes sense as a support strategy for a primary intervention. So let's just review the definition of cardiogenic shock, and I think this patient you'll see meets many of those definitions. Clinically, shock is a syndrome of diminished cardiac output and vital organ hypoperfusion despite adequate intracardiac filling pressures. And the second component of that definition is critically important to differentiate cardiogenic shock from hypovolemic shock in the setting of, for example, massive hemorrhage, where there also may be diminished output, but with low filling pressures. So hemodynamically, the definition of shock is really as listed on this slide. This is clinically marked and persistent hypotension, and in most studies that's defined as lasting more than 30 minutes, and the mean arterial pressures that are included are there, systolic pressures of 80 to 90. If you have a pulmonary artery catheter in place, you could measure a reduced cardiac index, and typically shock is defined below a cardiac index of 2.1. And as I mentioned, filling pressures being normal or elevated are defined typically at a threshold of 15 to 18 millimeters of mercury. So with a PA line in place, you can make a hemodynamic definition of shock. The etiologies of shock are really diverse. And as we understand, if you spend any time in an intensive care unit in the medical side or on the cardiology side, there's a wide variety of ways in which patients develop shock, including in the recent era, patients who've developed cardiovascular complications of COVID-19. In the larger epidemiologic experience, about a third of patients in the modern era still have cardiogenic shock related to acute myocardial infarction. That is a smaller percentage than in the past. And what is growing is the percentage in the yellow pie piece, which are those with worsening heart failure from non-ischemic etiologies. But all told, it's still about 40–50% of patients who have some ischemic contributor to their heart failure, and the smattering of other reasons, including arrhythmic causes, transient injury from stress cardiomyopathy, fulminant myocarditis, including drug-induced myocarditis or viral myocarditis, and then valvular cardiomyopathies are certainly in there. Don't forget that pulmonary embolism and tamponade, as well as aortic syndromes that are acute, can present with shock and should be considered in your differential as you're reviewing cases for the boards. The pathophysiology of cardiogenic shock, independent of the specific mechanism, typically begins from a myocardial injury. Classically, that's a myocardial infarction, but it could be exacerbation of myocardial dysfunction for some other reason, inflammatory or otherwise. That results in acutely some decline in cardiac output and stroke volume, systolic dysfunction, which precipitates hypotension, worsening coronary perfusion, and downward spiral of ischemia that results in progressive heart failure and death. Simultaneously, as this happens, filling pressures are rising, which further exacerbates tissue hypoxemia and subendocardial ischemia, accelerating the downward spiral. So most of our strategies in shock are directed at restoration of adequate forward perfusion and reduction in intracardiac filling pressures. But remember on the left of this slide that shock is often attended by an inflammatory response that we've become very familiar with in the COVID era that includes elaboration of pro-inflammatory factors like IL-6, TNF-alpha, nitric oxide, that also may contribute to inability to compensate for the low output with intensification of systemic vascular resistance. And so in some patients with advanced stages of shock, there's actually a loss of systemic vascular tone that is related to this inflammatory response that exacerbates the initial decline in cardiac output, the double whammy, if you will, that really sends blood pressure down to the toilet. So what do we know about the epidemiology of cardiogenic shock? Well, we know that the incidence of shock overall as a complication of myocardial infarction has steadily increased over time, but the survival, partly because of our more aggressive strategies of reperfusion and more successful strategies for in-hospital stabilization, has actually improved. But I think the key message on this slide is that even in the modern era, shock related to complications of ST segment myocardial infarction remains a really condition associated with a very high rate of morbidity and mortality, nearly 40% in this sample from the nationwide inpatient sample. So what are the management goals in cardiogenic shock? And now I'll step away from an etiology-specific approach, but we're really going to focus on the paradigmatic example of the patient with acute myocardial infarction. The goals are fairly simple and follow from the pathophysiologic diagram I showed you. One is hemodynamic stabilization, which is maintenance of mean arterial pressure and end organ perfusion. We want to reduce myocardial work to diminish tissue hypoxemia and subendocardial ischemia. And we want to reduce filling pressures, but not so aggressively that filling pressures become low and might contribute to further hypotension. But we want to eliminate that congestive stress that may further complicate myocardial perfusion. In patients with acute myocardial infarction, there's also a push for early restoration of blood flow, with the argument that restoration of blood flow will result in mechanical recovery and hopefully restoration of normal hemodynamic state. I think the challenge is that over time, shock tends to become more complicated, more inflammation, more metabolic complications, lactic acidemia that then sort of inhibit the response to some of the many interventions we use to stabilize hemodynamics. And this sort of creates the rationale as time goes on for more aggressive mechanical support, and we'll talk about that. So what pressors to use in shock? This is a favorite question for the wards, and the data, unfortunately, to answer it is fairly limited. This is, however, one of the few areas in shock therapy where we have randomized trial data, so I wanted to show it to you. This is data from the SOAP2 trial, 1,700 patients randomized to dopamine or norepinephrine as initial therapy. 280 patients were pre-specified in this analysis as a cardiogenic shock subgroup. And so if we look at the effects of norepinephrine versus dopamine overall, you can see that there was a trend favoring norepinephrine, but that trend was particularly favorable in the patients with cardiogenic shock. There was a higher rate of death also in the patients in the CS subgroup, but generally the point estimates favored use of norepinephrine over dopamine in shock, and this may be related to the lesser tachycardia associated with norepinephrine use. So the data is thin, but it does suggest that maybe earlier, if you're considering therapy in cardiogenic shock with a pressor, that perhaps norepinephrine is preferable to dopamine. I think if we look at the one very strongly evidence-based strategy in cardiogenic shock, it's early revascularization. And this is largely based on data from the seminal shock trial, which was not a large trial, but it is large by shock standards, 302 patients with acute myocardial infarction and cardiogenic shock randomized to initial medical stabilization versus early revascularization, defined as revascularization within 6 hours. And what this shows, and was really only borne out more prominently with longer-term follow-up, was that the early revascularization strategy was associated with a marked improvement in survival. And the statistical significance of this difference is enhanced when we look at longer-term follow-up. And it's really this that has girded the rationale for the very aggressive strategies for early restoration of blood flow and coronary blood flow in patients with acute cardiogenic shock. The question in the cath lab, of course, becomes when you see the culprit lesion, the occluded vessel that you think is responsible for the shock, what to do with all of the other vessels that might be partially blocked, but not acutely responsible, we think, for the presentation. We now have some data that perhaps focusing on the problem at hand is the best strategy, at least in shock. This is not true in myocardial infarction in general, where with complete revascularization during the index hospitalization seems to be increasingly favored. But in shock, the goal is to get in and get out as quickly as possible, doing the minimum we need to do to stabilize the patient. And this is data from the randomized culprit shock trial showing those patients who got multivessel PCI fared worse than those who got culprit lesion only PCI with regard to 30-day mortality, although the curves were fairly similar at 1 year. Who should get a PA catheter in cardiogenic shock? I've talked to you about hemodynamics, and certainly pressor selection in hemodynamics and the selection of patients for mechanical support is heavily informed by detailed hemodynamic data that might be derived from a pulmonary artery catheter. And indeed, our guidelines fairly strongly support, on the basis of limited evidence, utilization of a pulmonary artery catheter in patients with impaired systemic perfusion when the bedside assessment is just not adequate for guidance. There is limited data from retrospective propensity match registry-based analyses suggesting that it may even be a survival benefit to use of a pulmonary artery catheter in this particular setting, which really is distinct from the use, the systematic evaluation of PA catheter use in nearly every other setting, because in most other settings, there's a neutral or harmful effect of routine PA catheter use. I think in cardiogenic shock, there's fairly strong endorsement of use of these agents early on to help guide pressure and hemodynamic support selection. So in terms of the severity of shock, I think we all understand that there are patients with mild shock and patients with more severe shock who are falling apart in front of us. And there's been some effort to try and now segregate the population of patients who meet the hemodynamic definition of shock according to severity. This is one effort to do that, which is the amount of pressor support required to maintain mean arterial pressure. And you can see that the more medications that you need, the higher the rates of mortality. The other is an approach that's being favored by some of the recent publications from the Society for Cardiac Angiography and Intervention, which are new staging systems for shock that really graph fairly nicely on this, talking about patients with pre-shock versus those with a refractory shock at the end of the spectrum. But however you categorize the patients, what's clear is that as the need for medical support increases, the consideration of more aggressive mechanical circulatory support increasingly comes into play because there is a point of no return with regard to loss of end organ perfusion or irreversible secondary organ damage that we want to avoid. So in general, as shock gets worse, we're considering more and more the need for mechanical support. So why mechanical support in shock? Well, generally, it's to maintain perfusion of the end organs, including the kidney, the liver, and the brain, to reduce intracardiac filling pressures because mechanical unloading is typically more favorable or more effective than simply pharmacologic unloading. And we really want to relieve the myocardial wall stress that's driving that downward spiral of ischemia and shock, particularly in the setting of acute myocardial infarction, where we want to limit infarct size. And most of this data is really, as you're going to see, at the level of consensus statements and data from very small experiences, because that's what we have. We don't have large randomized trials of MCS and cardiogenic shock, but I'll give you what we have since some of these issues may come up in your board examinations. I think the first general message for management of deployment of mechanical support in shock is that in general, the patients with critical shock, those patients who are falling apart and having hemodynamic instability despite maximal pharmacologic support are not and those with incipient end organ failure are not the best candidates for an urgent surgery to implant a durable left ventricular assist device or biventricular assist device. Patients who are taken to the cardiac surgery in the throes of cardiogenic shock tend to do very poorly. What you really want is some initial mechanical stabilization with some temporary support device in order to make those patients a little bit more palatable as surgical candidates. And this is the data which really suggests that for level 1 shock, which is critical shock in the Intermax classification, you can see the outcomes are worse than those patients with milder shock variants. So how do we think about selecting mechanical support for patients with advanced heart failure and cardiogenic shock? Well, really, it depends a little bit on the etiology of shock, the anticipated prolonged duration of support. Do patients need left or right ventricular support, or why? And what is your long-term goal? I think that depending on the device we use, there may be the need to immobilize the patient, to leave them intubated for extended periods of time, and each device carries with it differential risks. And so we need to keep in mind, whenever we put in a device to support patients in shock, what the exit strategy is likely to be. Are we trying to recover the patient, or are we trying to stabilize them for a cardiac surgical procedure like a durable ventricular assist device? Are we trying to stabilize them until a transplant is available? Or are we really just trying to stabilize end organ perfusion to see if there's sufficient recovery to permit a next step strategy, in which case we're really implanting the temporary support device as a bridge to decision. But keeping in mind that exit is important so we know what the criteria are for peeling back support if we don't achieve our goals. So what are our options for acute mechanical circulatory support? Well, I already mentioned that we need to think about whether the left ventricle or the right ventricle or both need to be supported. And there's now a range of devices that are available that range from the minimally invasive, like the intra-aortic balloon pump on the left of the slide, to veno-arterial ECMO, which is essentially extracorporeal cardiopulmonary bypass that can be delivered at the bedside through peripheral cannulae. For the right ventricle, we have fewer options, but there are now some percutaneous options that exist for right ventricular support. And then certainly ECMO can be configured as VV for RV support alone. Let's start with the most familiar of these devices, which is the intra-aortic balloon pump, which is the traditional mainstay of mechanical therapy for cardiogenic shock. The concept here is that we have a long balloon that inflates and deflates in the descending portion of the aorta. The tip of the device is just at the takeoff of the left subclavian, and the proximal end should be just above the renal artery, so it's not obstructing renal blood flow. The concept here is the device inflates and diastole, deflates and systole to augment coronary perfusion diastole and reduced afterload. This device is effective in hemodynamic stabilization, but there's no definitive impact on mortality. And the patients who respond hemodynamically do seem to do better. So the use is considered in patients with STEMI when cardiogenic shock is not reversed with pharmacologic therapy, those with inotrope refractory heart failure, those with medically refractory VT, those with mechanical MI complications as immediate and rapid stabilization. Be mindful of aortic insufficiency or aortic injury or aneurysmal dilation of the aorta, which may be contraindications. There is some data about use of balloon pumps compared with medical therapy in shock, and it really doesn't support routine use of the balloon pump because in this trial, IABP Shock 2, there was no impact on 30-day mortality. So effective in hemodynamic stabilization in some patients, useful in that regard, but not clearly impacting long-term outcomes. What are the physiologic impacts? Some improvement in cardiac index on average and improvement in indices of perfusion, but on average, a modest improvement in cardiac output of only about ½ liter per minute. Sometimes that's enough, but often that's not enough for patients in the throes of more advanced shock. And this is one of the reasons that we think about more aggressive percutaneous devices. And the details here are hard to work through without using some of the trade names for the branded devices, but essentially one device, the tandem heart, is a left atrial to femoral bypass. Another is a retrograde cannula that is essentially a microaxial flow pump pulling flow from the left ventricle directly into the aorta. This device sits in the left ventricle and is implanted much like a balloon pump. The devices vary a little bit in the size of the cannulae that are used and the amount of anticoagulation and the specific complications, but generally both these devices provide more overall flow than a balloon pump does. And there are some comparisons in your packet for why you might select one or another. The most difficult to place is the tandem heart device. The Impella is comparable to placing a balloon pump, but positioning is often difficult. Hemolysis tends to be a problem with the Impella device, more so than the balloon pump. And I think the question really boils down to the expertise in your local laboratory and the techniques you have available. When we compare balloon pumps to mechanical circulatory support with these more advanced devices, what's clear is that on average, you get more flow, more improvement in cardiac index, and more reduction in filling pressures with the more advanced devices than with a balloon pump. But overall, the comparison does not suggest an incremental benefit with regard to mortality in a head-to-head comparison. So it's hard to say that these devices influence long-term outcomes, but they are undoubtedly helpful in short-term stabilization. What has happened over time, if you look at trends, is that on average, the use of the balloon pump has remained sort of the most prominent because it's the most readily available and even community centers have access. But you can see a steady rise in the use of short-term mechanical support in the solid red line here, which is devices like the Impella, the tandem heart device, or mimics. What we do know is that this is still a zone where we need more data, and this is site-by-site exploration in the Cardiovascular Critical Trials Network registry, showing that in shock, there's markedly varied utilization of advanced MCS over balloon pumps depending on the center. And I would simply encourage you for your center to utilize what the expertise you have at hand, but be mindful that if you're not getting enough support out of a balloon, there may be other intermediate options before moving to ECMO. So I'll close with a question about a woman at 37 weeks gestation who presents with a 3-day history of pleuritic chest pain. She has, due to concern for fetal distress, she's taken to urgent cesarean. On closure of the abdomen, she has a PEA arrest. Cardiopulmonary resuscitation is initiated and she gets ROSC in 20 minutes. Her blood pressure is still low, PaO2 is low, and despite an FiO2 of 1.0. She has poor perfusion, and you're called to discuss options for urgent MCS for stabilization. So my question to you is, what are you going to do? Are you going to give her a balloon pump, veno-venous ECMO, veno-arterial ECMO, a percutaneous right ventricular assist device, or a percutaneous left ventricular assist device? Sorry. So it seems like most people suggested veno-arterial ECMO, and in the interest of time, I think that's the right answer. This is a patient with refractory hypoxemia and hemodynamic instability. So in that setting, we need full cardiopulmonary support, and that is the role of ECMO. The ECMO circuit is typically configured in this fashion with some arterial, either a veno-venous cannulation, which is typically for oxygenation and isolated pulmonary support, where you're essentially running venous blood through an oxygenator and then back into the venous side of the circulation, or veno-arterial ECMO, where venous blood is pulled into the oxygenator, oxygenated, and then deposited on the arterial side of circulation for a complete cardiopulmonary bypass. Flow can be up to 4 to 5 liters per minute, depending on the cannula size, and all patients need anticoagulation. This is complete cardiopulmonary support. There are many different configurations, and I won't dwell on these, but I've talked you through the 2 paradigmatic options, which are veno-venous and veno-arterial ECMO, and the indications for each depend on what support you need. If you need isolated pulmonary support, typically veno-venous support will be adequate. So this is paradigmatically the patient with influenza and severe cardiopulmonary failure. But the patient who has cardiopulmonary failure, not just pulmonary failure, might require cardiopulmonary bypass. So the patient with cardiogenic shock from advanced heart failure might fit in the second category. There are no randomized trials of efficacy of VA ECMO and cardiogenic shock, and there are some concerns, including the risk of LV aortic or aortic stasis, of pulmonary hemorrhage, of coronary and cerebral hypoxia that we can discuss in the question and answer, and a number of complications to be aware of, notably the risk of stroke and limb perfusion abnormalities, as well as renal injury. We can certainly come back to these. No clear evidence of improvement in survival, but there is, in some selected cases, particularly influenza-associated myocarditis, some data supporting its efficacy. So the selection of devices for refractory shock really depend on whether you have really the need for lung support, heart support, or both. And if you need heart support, whether you need support for the LV or the RV or both. And I think this grid gives you a nice algorithm for thinking about the options in front of you. So I'm going to close there by just saying that care for cardiogenic shock has become increasingly complicated, and that because the options are protean, this is often a coordinated discussion between your interventional cardiology team, your cardiac surgical team, your heart failure service, and your critical care team, working together to kind of define a pathway for selection of appropriate strategies for stabilization and ultimate exit to improve outcomes. And these shock teams, deployed effectively, can improve overall care of patients with cardiogenic shock. So I'm going to close there and say that the options for management of cardiogenic shock are expanding. For medically refractory patients, early institution of mechanical support and reperfusion is key. Device selection should be tailored to the needs of the individual patient and your local expertise, and regionalized systems of care and collaborative shock teams may improve outcomes. Don't forget that you need an exit strategy whenever you're thinking about mechanical support, and consider the goals of care before transitioning to mechanical support, particularly ECMO, where withdrawal is challenging. So with that, I'll close, and I think we have a couple of minutes for questions, Dr. Winehouse, if there are any.
Thanks so much, Akshay. That was awesome. We do have a couple of questions, and I'm going to jump right in. One of our participants asked, are you using the SCAI classification system yet? And do you think it will help guide therapy a bit better for our cardiogenic shock patients?
So I think that just to review, the Society for Cardiac Angiography and Intervention is a cardiovascular society that has really tried to take on the challenge of how to segregate patients with shock into more fine categories, so that we could then define individualized strategies for selection of mechanical and pharmacologic therapy at each level of shock. And I think the first effort here by the SCAI is to put out an ABCDE classification that kind of subsegments shock into various categories, and then offers a suggestion about different approaches to therapy based on the level of shock. I think this is a great first step. I think what is often challenging is that the data to inform the segregation of the subcategories is still a little bit limited. And I think we need to refine this classification to be sure that we're defining clearly pathologically or hemodynamically distinct subsets to which we can graft differential treatment strategies. And some of these things need to be tested prospectively to see whether they're really the right way to approach this condition. But I think it's a wonderful first step, and we're all beginning to integrate it in some measure in the way we begin to think about patients. I think it's also been helpful to differentiate patients with isolated cardiogenic shock from mixed variants of shock, where there is low cardiac output and low systemic vascular resistance, since in those cases, the strategies might be different than in those patients with pure cardiogenic shock. So I think a lot to look forward to in that, but more data that needs to be generated.
And maybe just in the last 30 seconds, one of our participants asked, which type of IV fluid would you use for cardiogenic shock? Is it like sepsis? Would you use lactated ringers, or what's the role for colloids, for example?
Yeah, so not a lot of specific data in cardiogenic shock about the most appropriate fluid resuscitation. I think we've often been I think we've been a little nihilistic about this on the medical side and tended to utilize normal saline very often for volume resuscitation and volume expansion. I think the use of colloid is certainly reasonable in patients in whom there is concern for significant capillary leak or loss of oncotic pressure. I think that when pH is abnormal, certainly giving buffered solutions that might help to correct pH and enhance the efficacy of pressors makes a lot of sense. So I'm not sure that I have a strong opinion that's evidence-based on that front, but I think what's most important is getting the filling pressures up.
Thank you very much, Akshay.